Good morning. I'm Nora Obuck with Edwards Life Sciences Professional Education Team. On behalf of our leadership, our team, and today's speakers, I would like to thank you for joining today's symposium, Hypotension Prediction, a New Frontier in Critical Care. It's well established that patients need both pressure and flow for optimized tissue perfusion. Advances in technology can now alert clinicians to the likelihood of a patient trending towards a hypotensive event and can provide additional information as to the root cause of the instability. This session will review physiologic principles around hypotension and shock, introduce the Acumen Hypotension Prediction Index, or HPI, and demonstrate its application through case studies. Before we get started, I would like to invite you all to interact with our speakers. During this session, you can use the chat function to chat live with the presenters. You may also visit our booth after the symposium for an opportunity to video chat with today's presenters. Each of their availability is listed in the tab to chat with an expert. Our first speaker is Dr. Alan Heffner from Carolinas Medical Center with Atrium Health in Charlotte, North Carolina. In addition to his role as an ICU director and intensivist, he commits his free time to educating nationally on sepsis and acute critical care illness. Dr. Heffner will begin our presentation with the principles surrounding hemodynamic instability.
Thank you, Nora, and thank you for the invitation to speak today. I get to provide part one of this event presentation. This series is entitled Hypotension Prediction, a New Frontier of Critical Care. And the first lecture, or the lead-off lecture, is intended to establish some foundational principles around blood pressure management and hypotension in the intensive care unit. I'm a practicing physician at Carolinas Medical Center in Charlotte, and this is going to be a clinically based and clinically oriented presentation. By way of disclosures, I've worked with Edwards Life Sciences in the past, specifically providing education focused on hemodynamics, shock, and resuscitation. The goals of this content are fairly straightforward. I'm going to review our current understanding of blood pressure as a marker of cardiovascular wellness. We'll highlight the dangers associated with systemic hypotension in acute critical illness, separating both their utility in recognizing high-risk patients, but also the risk of even brief hypotension among the patients that we're managing in the intensive care unit. And we'll review opportunities to improve outcomes by minimizing and avoiding hypotension in the patients that we take care of every single day. Our paradigms of shock are complex. It doesn't come as a surprise to this audience that when we manage patients in shock at the bedside, we often categorize that shock by several different tiers. We certainly recognize or strive to identify the underlying disease. We try to categorize the shock into specific patterns to help us both implement correct therapies and make sure we have the correct diagnoses. But we often underestimate the first step of shock management, which is shock recognition, and specifically understanding the physiology of shock, the compensatory response to shock, and therein categorizing our shock in our patients. While acute circulatory failure is defined by inadequate oxygen delivery and hypotension is not in that definition, many people continue to believe that hypotension is the sine qua non of shock. It is true that hypotension is a defining feature of uncompensated shock, but recognize that the majority of the patients that we take care of every single day, or that we have a first attempt to resuscitate out of cardiovascular insufficiency, have a normal blood pressure. They're able to compensate. They're able to preserve their systemic blood pressure. They're in a compensated form of shock. Although it's harder for us to recognize patients in that stage of shock, the truth is they are much more treatable. The outcomes of patients that we recognize and treat in compensated shock are far better than patients when they've reached that final stage of uncompensated shock that foretells exhaustion of our physiologic mechanisms. This is not a new construct. The paradigms of managing patients with acute blood loss, whether that's medical or traumatic, our attempts to recognize cardiogenic shock early, well before the onset of hypotension and severe malperfusion, are paradigms that we've been using for years. And I'll highlight that our new interest in cardiogenic shock has reignited an interest in our ability to recognize cardiogenic shock early, well before the patient is in extremis, as exemplified by the apex of this pyramid in red. The physiology of blood pressure protection is interesting. We as humans are similar to other large mammals in that our physiology is designed to protect blood pressure and not blood flow. This is a simple experimental model. You've probably seen this a demonstration or something akin to it in the past, and it shows our ability to preserve blood pressure despite fairly severe acute circulating blood volume loss, in this case, a hemorrhage model. And so persistent normotension is the norm in the majority of our patients despite acute circulating blood loss greater than 20%. So this is just an example of how robust our compensatory mechanisms are and how we are literally built to preserve blood pressure. The mechanisms by which that occurs are well known to you. We take those compensatory mechanisms as important signs for us to recognize a patient in the early stages of shock, as exemplified by the cartoon on the right side of the screen. This is an experimental demonstration in an unpublished model that exemplifies the same thing I just mentioned before, that despite a severe physiologic stressor or illness, the animal is able to protect blood pressure for an extended period of time. That category in yellow is the period of compensated shock. And then finally, once that physiologic reserve is exhausted, is overwhelmed by the physiologic stressor, only then does the animal go into uncompensated shock, which is heralded by hypotension. Now, this idea that hypotension is important has been around for a long time, but it is important for us to recognize that we've gathered a lot of information over the past 20 years to show just how dangerous it is for our patients. Some of the work I'm going to show you in the next two slides is from a longstanding colleague and researcher who put a big spotlight on the risk of hypotension among patients presenting to the emergency department. This data set is from patients in the out-of-hospital setting, but it shows some important points. Number one, the risk of even brief hypotension increases with decile of age. Okay, it's more important for their older patients. They don't suffer the consequences of hypotension lightly. The other important point is what we demonstrated is that that systemic blood pressure threshold of a systolic blood pressure of 90/100 is important. Falling below that threshold is an inflection point on the curve of danger for our patients. And the last point is the demonstration on the left of the slide that shows even brief episodes of hypotension, self-limited hypotension, are important for our patients. They portend that the patient is in dire straits and needs our attention. This is another cohort with similar data from the emergency department. Again, the degree, the duration, and even episodic hypotension is dangerous to our patient. Now, this was important information because it was a charge for us to recognize high-risk patients early. This was a data set that was compelling for us to recognize that even brief hypotension is dangerous to our patient. It pushed us to recognize that finding quickly, to get into the room and understand the patient's physiology, to implement treatments and resuscitation that was going to change the trajectory of that illness. Many of us have incorporated that same paradigm and those same thresholds into our resuscitation protocols in the hospital. Hypotension below that systolic of 90 or a mean of less than 65 is a standard criteria for my and probably your high-risk sepsis clinical pathway. And the corollary to that is we use these same thresholds as therapeutic targets. I like to simplify some of our resuscitation tenets when it's possible. And what you see on the right is the education that we provide in our education around sepsis and general shock, meaning let's make sure the patient has a sustained mean arterial pressure greater than 65 millimeters of mercury. Let's start norepinephrine at a reasonable dose right out of the gate so that we get the patient blood pressure support that they need. And the last tenet is probably even more important in today's world because we recognize, as I'm going to show you in a couple of slides, that even brief hypotension in our patients is dangerous. Hypotension is dangerous because it is a sign of the patient's severity of illness, but we recognize that even under our care, even brief episodes of hypotension that are potentially avoidable are important for the patient. So we're intolerant of hypotension now, and while our historic paradigm is to fluid resuscitate and only after exhaustion of fluid resuscitation do we add a vasopressor, I want you to think of those as therapeutics that we can apply in concert rather than in series. Now, I'm a bedside clinician. I want to provide some call outs to things I've recognized through years of invested practice, and that even when we recognize that hypotension is a dangerous sign, there's a pitfall. There's a pitfall because not every patient, especially in the early throes of hypotension, shows immediate signs of hyperperfusion. And that creates a opportunity for us to come to illogical rationalizations, to believe this patient looks too good to have that blood pressure at 80, to believe that the normomentation tells us that hypotension is not important. And I would also highlight that we tend to use a lot of euphemisms in medicine to include calling hypotensive shock a little hypotension or a soft blood pressure. And that is important because it minimizes the importance of that finding. It sends the message to our team that it's not as dangerous for the patient as it really is. So beware of these signals, beware of these communication faults, and recognize again that hypotension is dangerous. All right, now what about the evidence for hypotension in the intensive care unit? Well, in the past 5 years, we've got some growing information out of some very large and well-constructed databases. It's important to recognize this data set as slightly different than the data from the pre-hospital and emergency medicine setting, where the intention was to recognize high-risk patients. Once the patient gets to the intensive care unit, they're there for a reason. Someone has recognized them as being critically ill. We have a working diagnosis. We know that they have an important disease and that blood pressure restoration or blood pressure support is one of our foundational points. But even despite that, and in all of these case series, recognize that cumulative hypotension was dangerous to our patient, that even brief episodes of hypotension was associated with acute kidney injury, acute myocardial infarction, and death at 30 days or thereafter, meaning it was a very important marker. Now, obviously, we didn't randomize these patients to suffer hypotension, but these were independent markers of adverse outcome. And again, recognize that these patients were suffering this hypotension under our watch in the intensive care unit when blood pressure management was one of our goals. And so to me, this is a call out for us to be even more protective of our patients when it comes to avoiding and reversing hypotension. This is some of the work from my group over the past years, where we took a specific interest in the intersection of emergency airway management and hemodynamics. And what you'll notice at the bottom of the slide is that a large number of our patients in the emergency department and in the intensive care unit suffer shock following intubation that was not present, hypotensive shock at least, that was not present prior to the intubation, an incidence between 1 in 4 and 1 in 2. And it wasn't benign for our patients. Post-intubation hypotension, again, was independently associated with adverse outcomes in these patients. So another forewarning sign. Hypotension is dangerous for our patients. We need to be watchful. We need to be vigilant to avoid and protect our patients from hypotension when possible. Well, how do we do that? Well, one of the mechanisms is recognizing patients well before they get into uncompensated shock. Again, the signs on the left or the signatures on the right that we use at the bedside every single day are useful for us to recognize when a patient is in the throes of attempted compensation. Tachycardia or relative tachycardia codified by a shock index, abnormal perfusion with distal vasoconstriction as an attempt to maintain blood pressure in the face of falling stroke volume or cardiac output, supernormal lactate, subnormal SCVO2. These are all helpful markers at the bedside to recognize that a patient is physiologically attempting to compensate for abnormal oxygen delivery. So use these in a patient, even with normal blood pressure, to recognize their need of resuscitation. Now, why is that shock bad? Well, this is an illustration to show you a couple points. This is another animal model, and this is using intravital microscopy of the small intestine. And what you're going to see at baseline is fairly normal gut perfusion. This is a hemorrhage model, and it's a non-lethal hemorrhage model. It's a hemorrhage model that approximates just under 25% circulating blood vols, which you'll remember is a threshold that typically does not induce hypotension. What you're going to see here is that even with 10 and subsequently 20% circulating blood loss, you have significant alterations of gut microperfusion. This is compensation at work. This is the body diverting circulating blood flow from the gut, which is not essential at that moment in time, to other organs that are. This is what's happening even for brief moments of uncompensated and compensated shock in our patients. This is the reason they suffer end organ dysfunction. This is the reason that the systemic inflammatory response is upregulated in the context of shock, because even precious minutes of gut malperfusion can lead to gut barrier breakdown. So I don't want you to minimize the consequences of even uncompensated shock. If we had intravital microscopy in all the patients that we're managing on a daily basis, we would be much more insightful as to the underlying consequences of malperfusion. A couple important take-home points. Number one, as I mentioned before, our greatest benefit of recognizing shock is recognizing patients in early form of uncompensated shock. It's our greatest potential for rapid reversal, but it comes with the corollary that it's harder to recognize, okay? Compensatory clinical signs are imperfect. I would add that they're often underappreciated, which is an opportunity for us as providers to be more vigilant, to be more diligent. But we also need to expect more insight based on a new generation of hemodynamic monitoring. Another way of saying the same thing is that there are physiologic insights beneath the surfaces of our current monitoring. And the addition of these insights may help provoke us to recognize shock early, to recognize high-risk patients with forewarning signs that are clinically imperceptible to us, and lead us to treat patients more aggressively and differently than we did before, and therein avoid episodes of hypotension and the consequences of that to our patient. Let's summarize a couple take-home points. Blood pressure is an important, but unfortunately an imperfect sign of cardiovascular wellness. Blood pressure is strongly protected, and what that means is we only develop hypotension in the context of an overwhelming physiologic stress. That means uncompensated shock heralded by hypotension is a late sign, an insensitive sign for our patient's degree of illness. But we need to recognize that it's a true red alert. Even episodic and transient hypotension is an important and dangerous sign for our patients. Don't underestimate it. Next, compensated shock is an important opportunity for early care and resuscitation. It's an earlier sign of illness. It is a patient population that are more amenable to early and appropriate treatments. But the hard part is recognizing compensated shock. Recognition rests on clinical diligence and understanding the typical and classic compensatory markers of shock, coupled with some of our new biomarkers and other laboratory findings that substantiate those abnormalities. Now, another interesting point is that there's a lot under the surface. Subclinical insights into cardiovascular physiology are available to us. Prediction algorithms may help us recognize signs of early physiologic stress that are unappreciated at the bedside and predict onset of hypotension before it occurs. That's an introduction to the next lecture in this series. Thank you for participating.
Dr. Heffner, thank you so much for that excellent review on hemodynamic physiology. Up next, we have Dr. Mike Scott, who currently serves as the Division Chief for Critical Care Medicine at the University of Pennsylvania. Dr. Scott will introduce the Acumen Hypotension Prediction Index, or HPI software, and discuss how he has leveraged the data obtained with the Acumen Analytics software.
Thank you very much for that kind introduction. This is my disclosure slide. So I'm going to focus on the Acumen Hypotension Prediction Index software and give an overview of the monitor's graphic interface, what the actual HPI number represents, and discuss the three other parameters displayed in the secondary screen, which is SVV, dP by dt, and EA dyne. We're then going to discuss some of the clinical applications. So when a patient is admitted to the hospital for major surgery or into the intensive care unit, it's very common for us to have an arterial catheter in place. The catheter uses a signal from a transducer and displays a continuous beat-to-beat blood pressure. The blood pressure helps us know that we're delivering adequate perfusion to the body and tissues. And it's also extremely useful because it gives us beat-to-beat display of the circulation. What we're looking at here is a typical arterial waveform with just a single waveform broken down into its different components. And I think we're all aware that from the different parts of the waveform, we can interpret what's going on with the patient's physiology. So at the start of the waveform in the upstroke, we've got the effect of contractility. We've then got the peak of the systolic waveform and the aortic compliance effect. Then we've got the dicrotic notch. And then we've got the diastolic phase, which is obviously proportional to what's going on with the flow through the vessels and the afterload or peripheral resistance, which is the diastolic phase. We use arterial waveform analysis every day because it's so simple and relatively safe and cheap. It gives us a real display of the circulation, but it doesn't just give us systolic and diastolic blood pressure. We learn a lot from the waveform, the shape, the upstroke, and the pulse pressure and stroke volume variation, which we can use during the respiratory cycle. So when you have a ventilated patient at about 8 mils per kilo, tidal ventilation, pulse pressure variation and stroke volume variation can be very accurate indicators that you've got adequate preload for your patient. In fact, really, when you think of it, I'm talking about HPI today, and we are, as clinicians, performing our own physiological analysis and interpretation every time we're looking at arterial waveform. So I'd like to illustrate this with a real-life case from one of my previous hospitals. I worked in a large cancer center, and we did an awful lot of major oncological resections, particularly liver resections, both open and laparoscopic. And what we did was use a technique to reduce secondary bleeding by using low pulse pressure anesthesia and control the circulation and blood flow to the liver. So the surgeon did their bit by reducing blood flow by using Accusa, but we also had a vitally important time during surgery by basically we would use low CVC, so we would effectively dehydrate the patient and also drop the pulse pressure. And this had two effects. It reduced splanchnic blood flow and also hepatic artery blood flow, so the liver could be resected with minimal blood loss. I'd like to show some video from such a case, and you can see as I play these videos that the top right is our baseline, and then the bottom left video plays, and you can see that the heart rate is about 63, the blood pressure 85/55, and then we got a constant MAC of about or end tidal sevoflurane of 1.2 and constant CO2 of 4.0. But as the surgery actually proceeds, you can see from the next video that despite all the other parameters remaining the same, the blood pressure goes down and the patient becomes hypotensive. So despite the fact that we're trying to maintain our physiology constant, it can be very hard for us as clinicians to detect this hypotension. So wouldn't it be wonderful to have a monitor that could look at the whole arterial waveform and predict this change? And that's exactly what our HPI is doing. So HPI looks at the whole arterial waveform and the relationship between the different components, not just those three different phases. And I think you're all aware, again, on the next slide, when after a liver resection and we've got hypotension, low pulse pressure, as we fill the patient with intravenous fluid boluses, the systolic and diastolic blood pressure increases, as does the pulse pressure, a reflection of increased volume stretching the arterial tree and increased tone. And this is reflected when we use the HPI device in real life as well. So HPI is a first of its kind technology which can predict the likelihood of a patient trending towards a hypotensive event. And we define hypotension as a mean arterial pressure less than 65 millimeters of mercury for less than 1 minute. And it's a very rich physiological signal, the arterial line, as I've already elucidated. And the waveform gives us information about strength of contractility, how much blood is ejected, and how compliant or stretchy the blood vessels are. There are over 2.6 million different features that can be derived from the blood pressure waveform. And on the next slide, what this shows is that not all of the features will be important or specifically predictive, but where machine learning comes in, there were from 2.6 million features, 2 machine learning techniques were applied to identify what ended up as the 23 most predictive features. These features are not just single characteristics, but a combination of factors which incorporate how different characteristics interact with each other. So the data set included over 1,300 patients. This might not sound like a large number, but when you consider the physiological data that was collected, the number of patients provided over 130 million individual heartbeats. So what is the actual HPI number? It comes on a scale of 1 to 100. The higher the number, the higher the likelihood that hypotension, i.e. a mean arterial pressure of less than 65 millimeters of mercury occurring for a minute or more, will occur, the shorter the time to the event. So for example, on this slide, I've highlighted the HPI range of 85 to 89, and that gives you a likelihood that the patient will have a low blood pressure of around about 90%, and the average time to the event is 5 minutes, with a range of 2 to 10 minutes. This is an example of an individual patient. On the top, we're looking at the mean arterial blood pressure of the patient. When that patient blood pressure falls below 65 millimeters of mercury, that's what we define as hypotension. And that's where, as we know, the increased risk of kidney injury and myocardial injury occur. The bottom graph is the HPI number. And you can see that HPI reached the alert threshold of 85 or more before, around about 15 minutes before that actual hypotensive event occurred. The blood pressure remained stable during that time. So as a clinician, you might not be expecting a change. And I think I illustrated that with the 2 videos. And then suddenly the blood pressure can fall away quite quickly. So the advantage of the system, it gives the clinician almost a 15-minute heads up that something is about to change and that you can actually do something, be proactive and intervene to control that low blood pressure or actually decide what you need to do to affect the change. And that's where the secondary screen comes in, and I'll come to that very shortly. So some of the evidence base behind it, this is one of the studies that supports the use of the technology in the clinical setting in surgical patients. And they showed that in over 300 patients, that HPI was very reliable at predicting hypotension. And there was no other real hemodynamic parameter that we could rely on in the same way. So how can we use this technology in clinical practice? We can use it in the operating room to reduce hypotension perioperatively, but I'd like to propose we can also use the technology in the post-operative or critical care space. So using HPI, we can be proactive to reduce the amount of hypotension that our patients have. And this is important because we know that over 50% of hypotensive events are in the 12 hours following surgery, not always in the operating room. Also, we can use it as a bedside decision-making tool to help us decide how we can fix the hypotension. I'll give some examples of that shortly. There are also new parameters that might prove clinically useful to titrate vasopressors. The Acumen HPI software is comprised of 3 key elements. The first is the HPI parameter, which I've already shown you. And then when this reads more than 85 for 2 consecutive 20-second readings or reaches 100, an alarm pops up, which prompts you to go to the secondary screen. On the secondary screen, we can then view the other parameters: stroke volume variation, dp/dt, and EA-dyne, and work out what the likely cause of the hypotension will be. This is a view of the secondary screen. In the top right hand, you can see the HPI parameter. So just to remind you, so that's in red at the moment. It displays a value ranging from 0 to 100, and with higher values indicating the higher likelihood of a hypotensive event. And it's updated every 20 seconds. If the value exceeds 85, the auditory alarm will sound. And if the HPI parameter exceeds 85 for 2 consecutive readings or reaches 100 at any time, the pop-up window will appear, prompting you to review the patient's hemodynamics using the secondary screen. So the first thing we can review is the stroke volume variation, which, as you all know, is the percentage difference between minimum and maximum stroke volume during a respiratory cycle. So that's really reflecting preload. The next is dp/dt, and the arterial dp/dt is the maximum upslope of the arterial pressure waveform measured from a peripheral artery. The trend values of dp/dt may be an indicator of increasing or decreasing contractility. And finally, EA-dyne, which is dynamic elastance. EA-dyne is simply the ratio of PPV to SVV. It's a measure of the afterload to the left ventricle by the arterial system relative to the left ventricular elastance. So in the same way we consider dynamic parameters like SVV to predict fluid responsiveness, EA-dyne has been shown to be an indicator of pressure responsiveness, predicting if blood pressure will increase in response to fluid administration in preload responders, but it should only be considered when a patient is fluid responsive. It's not a valid measure of pressure response in preload independent individuals. These 2 clinical trials showed how using Acumen HPI software in combination with a therapeutic protocol, clinicians managed to proactively implement strategies that reduce the incidence and duration of intraoperative hypotension. I did something very similar myself at my last institute at Virginia Commonwealth University in the operating room in cardiac surgery. And here you have a picture of us using the HPI software. We use the technology, and despite us using multiple inotropes and vasopressors, you can see that we actually had a very high sensitivity and specificity at both 5, 10, and 15 minutes. And these were confirmed by our ROC curves on the left. So using the secondary screen allows you to have a deep dive into the trend of SVV, dp/dt, and EA-dyne, and adjust your vasopressor or inotropic infusions accordingly. When we did the VCU data collection, we used something called the Acumen Analytics software. And this tracks hypotension and duration, and even can track other things like cardiac index. And it's very useful for us when we wanted to instigate a hemodynamic optimization platform for our patients, because we could map what practice was and then see how we changed and see if we had an effect on the number of hypotension episodes. Finally, I'd like to introduce an interesting paper to whet your appetite of how this new technology can be used. This paper studied septic patients and measured EA-dyne before reducing the infusion rate of norepinephrine. So they were basically stable on ventilated patients with stable norepinephrine and fluid requirements, and EA-dyne was measured. You might be asking, how was stroke volume measured in these patients? And it was using the PICO thermodilution technique. So by knowing stroke volume variation and pulse pressure variation, you can work out your EA-dyne. And they mapped EA-dyne and looked to see what your risk of your mean arterial pressure dropping if you actually reduced your norepinephrine infusion rate. And the results were very impressive. They showed that an EA-dyne less than 0.94 predicted a decrease in your mean arterial pressure with a ROC curve of 0.87 if you actually reduced your norepinephrine. So what that means in real life is if you've got an EA-dyne of less than 0.94, you probably shouldn't be weaning your norepinephrine because the patient's going to become hypotensive. Whereas those with higher values, you're safe to do a trial of weaning of norepinephrine. I'd like to summarize by showing the secondary interface screen. The mean arterial pressure and cardiac output are displayed along with the HPI, in this case 86 out of 100. Preload is represented by stroke volume variability, and contractility is represented by dt. Afterload is represented by dynamic arterial elastance, EA-dyne. Thank you for your attention. I look forward to taking some questions later.
Dr. Scott, thank you for introducing the Acumen software suite. I think we can all appreciate you breaking down how the data for this algorithm was obtained, as well as providing clear explanations for HPI and the secondary parameters. Richard Bengel will now walk us through what it looks like to actually apply these parameters at the bedside through case studies. Richard currently works as a cardiac surgery PA at Our Lady of Lourdes Hospital in Philadelphia, Pennsylvania, where he currently uses HPI in practice. Let's have you go ahead and take it away.
Hi, everyone. My name is Richard Bengel. I'm a cardiothoracic surgery and critical care physician assistant at Virtua Lady of Lourdes in Camden, New Jersey. And today we're going to talk about the clinical application of HPI. Just a disclosure, I'm Ricky Bengel. This is a paid consultant for Edwards Life Sciences. And let's get started. So this is our screen. This is our Hemosphere screen. This is going to be the user interface that you're actually going to see when you hook your arterial line up to the Hemosphere. And these numbers here are the hemodynamic numbers that we're familiar with from using other monitoring devices such as a Swan Gans. And up in the right-hand corner here, this is your HPI. This is your hypotensive predictive index, a scale of 1 to 100. Closer you get to 100, like Dr. Scott said, the likelihood of hypotension increases. Down here are your cerebral sats and your tissue oximetry. We're not really going to talk too much about this today, but this is interesting stuff to talk about. And then you have your trend data here. These lines here are just the trend of what's been going on with the patient. These are live updating. These are your actual live numbers, what's going on currently with your patient. And this is all customizable. You can put whatever variables you would like here. If you would rather use cardiac index instead of cardiac output or stroke volume variability, this can all be changed. And for discussion purposes, we're going to define hypotension as a MAP less than 65 for 1 minute. The HPI correlates with numbers, and these numbers are going to be on a chart that's going to be on the device. And as you can see here, your HPI is a scale of 1 to 100. This is your event rate, which is pretty much what's the likelihood of becoming hypotensive. And then this is your time to events in minutes. So we can see here, we start low. Let's start at 10. We see that there's a 13.8% chance of becoming hypotensive in 51 minutes. Our patient on the last screen we saw was about 38. So we see that there's a 35% chance of becoming hypotensive in 45 minutes. So this is pretty far away, but as you can see, as we get closer to 100, let's skip down to 95 to 99 on the HPI, we have a 99.6% chance of becoming hypotensive in about 90 seconds. So this chart is an ICU chart. There's another one that correlates to the operating room, but this is going to be your scale of how likely the patient is going to become hypotensive. Looking at these screens again, this is the original screen that I showed you without the red circle there. So same number, same hypotensive predictive index here. And what we're going to see is these trends, and we're going to see this HPI rise, and it's going to rise and fall just like we see our MAP, our SVR, stroke volume. But what's going to happen is as the HPI approaches 85 twice or above 90, what we're going to see is this alert screen pop up. And you can touch the button, touch screen. You can acknowledge this and continue on your course of action, or we can click this more information button, and what it's going to do is it's going to take us to a secondary screen. Our secondary screen is this. This is a simulated screen. This is not the same. However, this is exactly what you're going to see on your device. And what it's going to do is it's going to break down the factors of hypotension. So what we can see here is a HPI of 86. You can see our MAP of 75. We've got two arms of this decision tree. Let's go to the simple one first, your SVR. This is your after-allergic systemic vascular resistance. We can see here about 1,700. And then when we go down to the left side here, in this yellow box, you see your cardiac output of 3.5. Going down into the factors of that, you see your pulse rate, you see your stroke volume, and then your factors of your stroke volume variability, your DPDT, which is your contractility, and your EA dyne, which is your dynamic elasticity of your arterioles. And what we can see here is nice color-coded for us to tell us what the problem is. But this is going to give us a bigger picture of what's going on with our patient other than what we're currently seeing. And what we can also do here is we can trend the data. And this is a percent change, so 20% down here in MAP, 34 down here in cardiac output, SVR increased 23%, and this is all over 5 minutes. So we can change all this, but this is a good trend line to see where our patient's going. Of note, since we're talking about functions of the screen itself, what we're able to do is we're able to implant interventions. So when we do something like start a pressor or give a fluid bolus or give blood or a vasodilator, what we can do is we can click this button here. It will implant one of these, and we can actually implant what we did to the patient there, and we can see the trend lines after we did that. So let's take a look at what we did to this patient here that caused this dramatic rise in SVR that didn't really affect our cardiac index or our stroke volume all that much. This patient was started on neosynephrine. So we got the appropriate response in SVR, which we saw was 500 on the last page, and this is what we're able to do for all of our interventions. Let's talk about some cases now. We're going to talk about 2 cases. This first case here, we're going to talk about the operating room and continuum of care into the ICU, and the second one is going to be more of a simulation. So let's get started. This is a 73-year-old female, past medical history, hypertension, hyperlipidemia, TIAs, 4 stents in the past, and an ejection fraction of 35 to 40%. She underwent a CABG ×3. And after the case, what we do is we download our data and we put it into the Acumen Analytics software. And this is our first page. This is our summary page. It's the first page you're going to look at. In the upper left-hand corner here, this is just demographics about the patient. This is the date of the surgery, weight, age, female. On the bottom right-hand corner, this is usually what I look at first as far as our hemodynamics during the case. So you see our procedure time is 1,600 minutes. It's about 24 hours. So you can tell there. That's the case plus the ICU length of stay, or I'm sorry, the ICU time that we had the hemisphere on. You can see 161 of those 1,600 minutes was hypotension. That's about 10% of our time. It's not bad, but not very good. And then what we're able to do over here is we're able to break down those statistics a little bit more. And what we see here is a map of under 50. We have no events there, so that's pretty good. And we see an average map of 61. That's not that bad. And then we look at our average hypotensive times. So meaning that every time that we were hypotensive, how long did it take for us to get back to a normal tensive state? And we see here about 7 minutes. And like I said, this box here is usually the first one that I look at. This really gives you an idea of how hypotensive that patient was. Because we know every minute of hypotension really makes a difference in a lot of patients. What we're able to do from the Acumen Analytics then is we're able to do a trend analysis. So what we're able to do is we're able to look at all of our factors, the same ones on our secondary screen on the hemisphere. We're able to look at through a retrospectoscope to say, and look at what happened during the case and during the ICU. And so let's just talk about what we're looking at here. So we're looking at the map and we're looking at the HPI on the screen. On the next couple screens, we're going to look at the SVR, the SVB, the cardiac index. We're going to look at a bunch of other things. And this blue line here is our delineation between the OR and the ICU. And this break here is the time that we were on pump and we paused the device. And then what we see here are these two blue arrows on each of these graphs. These are going to be interventions. So let's take a look at what we did here. In the operating room, it looks like we had a pretty decent control of our map. It looks like we don't become really hypotensive all that much. A couple little blips here, but overall okay. And we look to see our correlation with our HPI. And what we can see here is you see the HPI did alarm quite a few times, but this patient was treated appropriately, it looks like. We never actually became hypotensive, so that's a good thing. But then let's look at what goes on over here. Our HPI kind of goes up and our map goes up, so we did something here. So let's take a look at what we did. And we added Levofed here. So we started a pressor for this HPI that was alarming here, and our map responded appropriately. But we see that we never really recovered. We see that our HPI still stays pretty high, and we're looking at our map that's staying below our 65. It's yellow and red here. It looks like we're still hypotensive, but it looks like we did something else. So let's take a look at what we did here. And we added a second pressor. We doubled down on what we thought the appropriate treatment was, and we can see that we never really got that much better until much later. We see that we finally get a map that's better. So let's look at our other parameters and see maybe if we could have done something a little bit better here. So now we're looking at our cardiac index, our stroke volume, and our systemic vascular resistance, and we can see here that we know that we really didn't become all that hypotensive in the operating room. Look, we had a stroke volume that was kind of low kind of the whole time, and our SVR was kind of high the whole time. This patient might have been a little bit dry coming into the operating room. You know, we're talking about a cabbage. So we're talking about people who might be diuresed before surgery or MPO at midnight. Maybe this person could have used a little bit of fluids early on, but then we see this instability here, and we really see it after this initiation of our Levofed. We see our index severely suffer. We increased our stroke volume we increased our systemic vascular resistance, our afterload, so much that it actually decreased our hemodynamics. Although it treated our MAP, it wasn't necessarily the best treatment for our patient hemodynamics. And we can see that when we doubled down with our second pressor, we kind of had the same problem. Our index still hangs out around 2, which is marginally acceptable, and our SVR hangs out around 2,000, which is not really what we're looking for. But we see our stroke volume kind of increase. So it looks like we finally got on the right page here with we need to come off the pressor, we need to give some volume, and you see that through the increase in the stroke volume here. The overall outcome of this patient, not terrible, but not exactly our goal either. We had an ICU length of stay of 5 days. We did not experience an AKI in this patient. We had an overall length of stay of 8 days. She was discharged home. But let's really talk about the complications of this course, where she remained on pressors for about 48 hours after surgery. And for those of you who do cardiac surgery critical care, you know that the beta blocker initiation is a big part of post-CABG. And while you're on pressor, you're really not going to start that beta blocker. So that's going to add delay to our length of stay, and oxygenation issues after eventually giving volume is going to lead to, supplemental oxygen needs. So that's kind of what held up our course. Not bad, but probably could have been better. Let's talk about a second case here. This is a 49-year-old male with a past medical history of hypertension, hyperlipidemia. He's an active smoker. He underwent a robotic-assisted off-pump CABG ×1. And this is going to be just the operating room, and we're going to do more of a simulation. But let's take a look at his Acumen Analytic page first. We see here, again, this is his just his demographics. We look down here in the bottom right-hand corner, normally where I go next, is 137-minute case, 26 minutes of hypotension, just about 19% of hypotension during that time. Overall fast case, not a lot of minutes of hypotension, high percentage, but relatively pretty good there. Again, MAP under 50, none of those. Average MAP under 65, 59, not so bad. And then it looks like we treated our hypotension pretty quickly here with only, the average duration of events for about, 3 minutes, less than 3 minutes. So treated very quickly. But let's get into the simulation a little bit. And let's talk about what we're looking at on this screen. So the big screen here with our EKG and arterial waveform, our SATs and our story, this is normally what's going to be on your monitor in the ICU or the operating room. And this littler screen here is going to be your hemosphere. And this is exactly what you're going to see on your screen. Although this is a simulation, this is exactly what you're going to see. And what you see here is your HPI 35, you got your MAP, your cardiac index, stroke volume variation, your DPDT, your contractility, your EA dyne, volume responsiveness, and your SVR, your afterload. And I know Dr. Scott just went through those parameters with you, so I'm not going to spend too much time talking about what all those mean. But what we can see here is you see a live EKG like you normally would, and you can see that this is live too. This is going to be our trend data, and it's going to move depending on what's going on with this patient. We can see here that your stroke volume variability is up a little bit, stroke volume's okay, all these other numbers look great, and your HPI is 35, very low chance of becoming hypotensive very soon. But let's speed this up a little bit, and let's see what happens to this patient. We see that the HPI kind of goes up to 50 here, and that correlates to a chance of becoming hypotensive, a 44% chance of becoming hypotensive in about 39 minutes. So we have plenty of time to treat this patient. But let's look at some of the other parameters here. We see our MAP is kind of the same, our index is good, our stroke volume is rising. We see our HPI click up there to 69. So now we know that hypotension is kind of getting closer to us, and we should really start paying attention to this patient. But there's not much to do because the MAP is 74. Here we see we're above 85 for the first time, so there's no warning screen that comes up. You see our stroke volume variability increasing, SVR still okay. Stroke volume now down to 66. So we're looking at maybe a little bit of hypovolemia. And now we're above 95. So here is our alert that comes up. And we can either acknowledge this and continue on our course of action, or we can click more information. We're going to click more information here. And when we click more information, it's going to take us to our secondary screen. And our secondary screen here is breaking it down. So our MAP 69, it's down 17% in 5 minutes. Our stroke volume variability is up 33% in 5 minutes. We see all of our other numbers look okay. Our EA dyne, volume responsive, probably what this patient's going to need. And what we're going to see is an intervention be done. And what we see is our provider leaves that screen and is going to click this button, and it's going to pull up an intervention screen. And this provider here picks a vasopressor. So we have our arrow here that says we started something, and we can see what happens after that. So we gave a bolus of Levophed here, and our HPI is still high because we kind of decided that maybe we need a little bit of volume at first. So we see that our MAP is still 73. We did not become hypotensive, but because of our actions, we've decreased our cardiac index, and our stroke volume variability is now very high, and our stroke volume is now very low, and our SVR is high. So this all makes sense, knowing that increased afterload and a decreased preload is going to drop down our cardiac index. You see our HPI drop because we're not going to become hypotensive soon unless we really treat these things. So what we're going to see is this bolus of pressure wear off, and our hemodynamics are really suffering now. Index of 1.6, stroke volume is very low, SVR is very high, and what we're going to see is the HPI quickly comes back up because we never actually treated the problem. So we're at 31 here, and then 44, and then 63, 75, 93. Here we are. We're back into the 90s, and what we see is now we're actually hypotensive. Our index is okay. Our stroke volume's low. Our SVV is high. We're going to do is click more information again, and we're looking at the same secondary screen here, MAP 67, and we see our stroke volume variability is now 18, and our stroke volume is 56, and we're now going to treat these numbers, and our provider is going to pick an intervention. So the provider picks an intervention. This time we're going to pick crystalloid, and we're going to see if that's the appropriate response to volume that this patient's going to have in the HPI. So the volume goes in, and quickly the HPI comes down. The MAP quickly increases. Your cardiac index is now 2.4, and we're going to skip ahead a little bit here. You see our HPI come down now to 29, the lowest it's been during this case. Our MAP is 71. Our index is great. We have a lowering stroke volume variation, and our SVR is now acceptable. And if we continue to move along here, we see that this patient really stabilizes, and we don't really have another event of hypotension because we actually treated this patient appropriately with that volume. You see that stroke volume variation really coming down now. Oops, sorry, it skipped back on me. We see the stroke volume variation now down to 15 and eventually 12. And we look good. We have a MAP at 81, our HPI is 28, index is 2.5. This is a patient who's going to do well. So let's talk about how this patient overall did. Let's talk about the overall outcomes. And so this case, this patient did well. Extubated in the operating room, ICU length of stay of 1 day, 3-day hospital course, discharge home, no complications. This is our goal from robotic cardiac surgery. So talking about COVID-19 discussion, in the beginning of COVID-19, there was not a lot of direction on the treatment on how to treat these patients, a lot of supportive care. And we found that by sticking the hemisphere on some patients and really getting a good idea of what's going on from the hemodynamics, we were able to better manage their fluids and their pressure status. In the beginning, we really were reluctant to give any volume because of how hypoxic they were, and we didn't want to flood their lungs and make their respiratory status worse. So we didn't give a lot of volume. We were riding a lot of pressure. And what we found when we put the hemisphere on our patients, we started to see that they were a little bit too dry, and we started giving some volume and some pressure use, obviously. I mean, it is a septic picture, so you're going to need both. But really, we had some goal-directed fluid therapy, and I thought that that was a big turning point for us in the ICU. That's really the topics 1 and 2 combined. They kind of play off each other. Topic number 3 there, you know, the high output cardiogenic shock. You know, you have your septic shock, which is your high output cardiogenic shock, high output shock, and you add that on top of people who are a little bit older, maybe some undiagnosed coronary artery disease or valvular disease, and then even a viral cardiomyopathy. You had to take all this into consideration when treating these patients and what you were going to choose to raise their blood pressure or give them volume. And by using, you know, DPDT, we were able to use this as a trend to treat the hemodynamics a little bit more in a scientific manner instead of throwing the kitchen sink and hoping something would work. And then the last topic there, the tissue oximetry. You know, in one of the earlier slides in this presentation, we talked a little bit about the cerebral SATs and the limb SATs. This was a good trend for our patients to see how they were doing. You know, in a typical picture, you have a low tissue oximetry, and because your body's uptaking that oxygen and using it. And then we would see that it would kind of uptrend and hang out around 100 if our body wasn't uptaking any oxygen. And we use the tissue oximetry to really guide our care and escalation and de-escalation of what we were doing for a lot of these people. And these topics are really what we thought were the biggest discussion points in our ICU using the hemisphere. Thank you for your time. I appreciate being able to speak with you all, and I'd like to open up the floor to some Q&A. Thanks again.
All right. Thank you once again to our speakers for their outstanding presentations, and especially to all of you for your ongoing work for continuously improving patient care. We hope to see you soon via the virtual chat option within the booth, and we hope you all take care and stay well. Thank you.